So good morning, everyone. Thank you so much for your patience this morning as we work through our technical issues. But thank you for joining us. I have a very special speaker this morning. I'm very honored to introduce Dr. Eric Genden. He's the endowed professor and chairman of the Department of Otolaryngology at the Mount Sinai School of Medicine. He's also a professor in the Department of Neurosurgery and Immunology. And he's really a well-known international expert and innovator in the management of head and neck cancer, microvascular reconstruction, as well as transplantation. He actually runs an NIH-funded lab that studies the transplantation immune biology of the trachea, and most recently was able to perform the first human tracheal transplantation. So for me, I want to give a personal thank you to him for mentoring and surgically training our last year's fellow, Dr. Scott Roof, who we all remember was excellent and amazing, and we loved training him. And he really hit the ground running when he arrived here after his residency. So a personal thank you. And so today, Dr. Genden will be sharing his journey that led to that first tracheal human transplantation. So thank you and welcome.
Thank you very much. I really appreciate the opportunity to speak to a group that has long been an influence and an inspiration for me in terms of the science and the work that we've done. This goes back to Dr. Strom many years ago in the late 90s and early 2000s, speaking to him about transplantation and transplantation science. I'm going to start out by not only thanking the group at the clinic, but the huge number of people that have been so important in my career. The science team, Lloyd Mayer and Susan McKinnon, but also Alec Patterson, who's the thoracic, and Joel Cooper, thoracic team at WashU. And Ralph Steinman, who the late Ralph Steinman, who was at Rockefeller University, and there's just a huge number of people that have been so incredibly important. All the work that I'm going to present today is work that really it stands on the shoulders of many of you, Dr. Lorenz and Dr. There's just so many people that have played important roles, and now with VCA transplantation and face and hand. It's become a very interesting area to study, and there's lots to do. A lot of people ask, way back when, I would get the question all the time, why not study laryngeal transplantation? And Marshall Strom at the time had a very big interest in this area, as did Dr. Lorenz, Rob. And the issue was that a couple of things. One, I thought that the larynx was extremely complex, and the complexity of the system made it a difficult one for me to think about starting. I want always to kind of step back and go with the most simplistic approach. Trachea doesn't have the problems of functioning nerve innervation to the larynx and the problems of synkinesis and so on and so forth. It's also a fairly complex organ made up of so many different structures that I thought it would be smarter for me to step back and take a look at something a little bit more basic. The other issue is that we were faced with this real clinical problem of tracheoesophageal fistulas, not just tracheal defects, but also TE fistulas that were, for the most part, universally fatal. And you can see the TE fistula on the left, and the placement, as usually is the cause or usually contributing, is a stent, an esophageal stent. It wears through, and inevitably these patients succumb. And I thought it would be interesting to identify a solution for this problem. So those were kind of the reasons. And we know that tracheal defects in and of themselves can and often do result from iatrogenic injury like intubation, burns, congenital TE fistula, and tracheal disease is a big problem affecting about 400 to 500 kids a year. But we've seen more of this with COVID and certainly malignancy, and these long segments are problematic. If they're cervical segments, we often are left with patients, and this is pretty typical of what we'll see, long segment cervical tracheal defects. Now these are compatible with life, they're quality of life issues. Something a little bit more difficult is when you have a thoracic tracheal defect, and we know that we're managing these patients with extended tracheostomy tubes. But inevitably, these things lead to progressive damage of the tracheal airway, and oftentimes lead to the TE fistula, which is where we were talking about earlier. Defects that involve both the thoracic and the cervical region are often incompatible with life, and we see a certain number of those. So this was kind of the dilemma, along with the TE fistula, that I had started to embark on really in the late 80s. Now, Dr. Grillo, who was at the Mass General, and as everybody probably knows, is really the father of tracheal surgery. I had the opportunity to work with on 2 separate occasions, both learning tracheal surgery, but also picking his brain about the possibility of transplantation. And I just presented actually to the Boston group and it related my experience with him. He was adamantly against tracheal transplantation, and the reason was he just didn't feel that there was a blood supply that we could use to revascularize the trachea. And he defined the fact that, look, you could resect up to half the trachea, almost 6 centimeters, and get this back together, but anything more than that was a real problem, and there was no solution to it. That being said, the literature is replete with approaches to managing these bigger defects, and we'll talk about that in a second. But the history, although is very interesting, there's a few kind of critical points. The first was back in the late 40s, early 50s, the use of fascia to reconstruct these large defects, and that really highlighted the fact that these would collapse under inspiratory pressures, and so it highlighted the fact that you needed a rigid structure if you were going to reconstruct long segment circumferential defects. The introduction in the late 60s and early 70s of alloplastics, which were thought to be the answer to this problem, because after all, the trachea is just a tube. Why not put a alloplastic tube in? What happened here was there was a problem with biointegration. These things would become either a nidus for infection, where they develop a biofilm, or also very commonly they would extrude and burrow into the surrounding vessels, leading to a fatal hemorrhage. The 80s brought in this denatured trachea, where they took human trachea, they denatured it of its antigens. This was started in Germany. We tried this. And the problem with the long segments, the Cincinnati group had the same problem, is that because there was no functional epithelium, these grafts would obstruct. And it was a critical point, because it really highlighted the importance of, if you're going to reconstruct long segments of trachea, this is actually not just a tube. It is a functioning organ, much like a kidney. And the epithelium that migrates and moves particulate matter out of the lungs, it turns out to be critically important. Not big deal when you're dealing with short segments, but long segment defects, if you don't have this intact mucociliary function, you obstruct and die. And so we created the tenets of long segment reconstruction, rigid structure, something that will biointegrate, and something that provides functional epithelium. And we felt strongly about this years ago. And in order to kind of to achieve these, we said, listen, you got to have a vascular supply, because this is in fact an organ that not only moves particulate matter out, provides hygiene, but it also processes antigen, and it turns out to be very important in the pulmonary antigen processing process. And if you're going to have a vascular supply for something like this, well, then the obvious answer is you need transplantation. And, if you go back to 1952, when Joe Murray did the first kidney transplant, this recognition that with microvascular reconstruction, we can only do so much. We can't reconstruct these highly complex organ systems. But the problem is that there was no vascular supply. And Dr. Grillo had floated this idea. We introduced a orthotopic mouse model that we used to study the immunobiology of the tracheal transplant. We thought that if we could understand the biology and the transplantation properties of the trachea, we would figure out the blood supply issue down the line. And so our laboratory for years was focused on understanding how the trachea functioned. And again, we stepped back from the larynx to do something what we thought was a little bit more simplistic. Some of the things we learned, which were really critically important, was the idea, as I said, about this mucociliary blanket in both pulmonary hygiene and antigen processing. The cilia turns out to be really important, and we know this from cystic fibrosis and pneumotile cilia syndrome, that if the ciliary function doesn't work, these patients can't clear the airway. And we'll talk about that as it relates to the transplant patient. But the most important thing is that this mucociliary function requires a bed of vascularization. You can't grow grass on a sidewalk. So you need a fertile vascularized bed underneath it. And if you take a look, and I don't know if this will play, the mucociliary blanket moves at 1,300 beats per minute, very directional, at about 2 centimeters a minute. You can see the particulate matter moving along. And video endoscopy demonstrates that this is a very active part of our pulmonary hygiene. In the mouse model, what we were able to do is demonstrate that if we placed in dye distally, we could watch very quickly the dye traverse the immunosuppressed grafted segment. But if the segment was rejecting, the mucociliary function was would not work, and in fact the dye wouldn't move through. Interestingly, in the mouse model, if you take the graft and you transplant it in backwards and immunosuppress it, the mouse will have difficulty with respiration. And the reason for that is that the mucociliary beat is the opposite way of what is needed physiologically. And it kind of highlighted to us, you know, if we're going to do long segment tracheal allografts, this function is really critical. And we spent a lot of time studying and understanding the different cellular mechanisms. And I'm going to stay away from the basic science. We'll touch on it a little bit. But some of the important things we found were that, number one, the MHC expression was really on the epithelium and some of the subepithelial stem cell niches. So the main source of allograft rejection, of allograft rejection in the trachea, is not the cartilage. It's actually the lining of the mucosa. And this mucosa turns out to be very interesting in the way that it functions. We've used imaging mass cytometry and digital spatial profiling to better understand when the trachea rejects, where are these immune cells and what is happening to the basal cells in the transplanted model. And suffice it to say that very interestingly, we typically think of allograft rejection, and this is a very important concept in terms of, I think, VCA, face and hand transplant. We think of allorejection as either direct recognition or indirect recognition of the donor antigens. But we weren't actually seeing this in our basic science lab, and we are now spending a lot of time looking at what's called the semi-direct route using exosome blockade, and we'll touch on that in a little bit when we get a chance. But one of the things we found, which I think was really important, was that when you placed in the donor graft, over the course of time, the recipient epithelium moved in and eventually relined the entire graft. And we use these reporter mice to demonstrate the green recipient epithelium marching into the donor graft. And this would happen very quickly so that the entire graft would become relined with recipient mucosa. So it would the graft would actually become an immunologic chimera. And in fact, when we would take these mice and we would transfer, do a transplant from the BALB to the C57 mouse, this would re-epithelialize and eventually become self over the course of 18 to 28 days. And then we could actually stop immunosuppression, and lo and behold, the graft would survive. And this was a very attractive concept because you can imagine, not just for adults, but also for children, if you were going to manage a large tracheal or tracheoesophageal defect in a child, to be able to give them induction immunosuppression, let the graft reepithelialize, and then withdraw or de-escalate immunosuppression. You could sidestep this toxicity associated with long-term immunosuppression. But the bottom line and the underpinnings of this whole thing is that, what about the blood supply, and how do you get this thing revascularized? And it was actually the work that your group did, Marshall with Dr. Lorenz had done, and that work demonstrating that, you could transplant this larynx, and in fact there was a piece of trachea that came with it, and it was vascularized, and that work was really critically important in us thinking about how could we do this. Again, back to Dr. Grillo's work, and this goes back to the 60s, in the mid 60s, where he did injections, and he would send me these articles, and for lack of a better word, we had very spirited discussions. And he'd say, look at how complex that blood supply is. I don't care what you think. You're never going to be able to hook these little blood vessels up and transplant an isolated segment of trachea. And he was very clear. So don't waste your time. Let's focus on ways outside of transplantation to do this. Salasa, who was at the Mayo Clinic, and Bruce Pearson kind of recapitulated this work using more modern techniques. But one of the things that they demonstrated that caught our eye, and had caught our eye earlier, was the idea that the vessels leading in from the inferior thyroid artery resulted in an arcade that fed both the esophagus and the trachea in the segmental work. And most of the work that had been done looking at tracheal transplant separated the esophagus from the trachea, and we kind of theorized that this was disrupting this very important vascular arcade. If you look back even further into the literature of people like Bougerie and others, the anatomic dissections, although they're not perfect because the inferior thyroid artery doesn't come off the carotid artery, but what it shows is the vascular network through the muscularis of the esophagus, this is the posterior view, and then going into the trachea. So this work here that goes back to the mid-1800s that Salasa and Grillo kind of rediscovered was really critically important as we thought about our allograft. And we did a series of injection studies. This goes back to 1999, looking at the vascular supply, and we found, in fact, that this was not going to work. And what was necessary is we had to take a segment of the esophagus posteriorly. And when you did that, and you kept intact this arcade, you could transplant huge segments all the way down to the carina with no problem. The vascular supply was beautiful. And we did a series of autografts, and then we did a series of allografts, and we demonstrated that you could get long segment reconstruction. The cilia were functional. The allograft functioned beautifully, and in fact, the canines did really very, very well with these transplants. Ultimately, using the work of Dr. Grillo and Salasa and the work going back to Bougerie, this is what we came upon for a tracheal allograft. It's not just the trachea. As per Marshall and Rob's work, the thyroid came with it, with the superior thyroid artery and vein, and importantly, the inferior thyroid artery with a segment of the esophagus. If you kept the esophagus intact, you preserved this arcade that in turn preserved this segmental blood supply to the trachea. And it turns out that this was very important. We were ready to go in 2006. The laryngeal transplant that had been done looked really good. We thought, wow, this is terrific. Vascular composite allograft, hand face was just taking off. We thought we were ready to go. And then something horrible happened. And that was the ushering in of the regenerative medicine and stem cell biology world. And literally within a month, we were seeing ears that were being grown in the backs of nude mice in petri dish. We saw cardiac valves, entire hearts that were being derived from stem cells and 3D printed material. And of course, we saw a trachea. And, we realized, gosh, of all of these incredible accomplishments, the trachea was going to be the easiest to regenerate using stem cell biology. It's, this tube. And at the time, Maccarini and Burchell and their group were kind of creating these things, and we thought there's just no place for immunosuppression or this big surgery if you can create this thing. And foolishly, and we've learned many lessons, we kind of shut down the lab. We said, this is not going to fly. We're not going to be able to justify that. And as we, some of you should know, and probably some of you who do this work know, Maccarini's work using this bioreactor to develop these beautiful tracheal segments looked like it was going to be the answer. We actually went up to Boston for the ATC meeting, our lab, and watched him present this work. And we looked at the work carefully, and one of the things we noticed very quickly was that he hadn't demonstrated functional epithelium. He hadn't demonstrated that there was this beating of the epithelium at that 1,300 beats, 2 centimeters a minute. We didn't see evidence of a functional graft, and we thought to ourselves, if this is going to be a long segment, I don't know that this thing is going to function. And we asked him the question publicly, and he wasn't happy with that question. Let's just put it that way. We were kind of put down in the area. And as most of us know, the series of transplants that were done, all of the patients unfortunately succumbed. They succumbed as a result of airway obstruction, interestingly. And it harkens back to this idea that if you can't support a functional epithelial construct, it's not going to work. And we tell people that the trachea is like the Rodney Dangerfield of organs. It never gets any respect. It looks like a tube. It feels like a tube. Just put a tube in, for God's sakes. It turns out that this is actually a functioning organ, and if it doesn't function, you have a problem. In Nature journal, there was a series of these articles outlining the misconduct and implicating not only the surgeon and researching team, but also Karolinska. And that created this tremendous pressure, because once that it had happened, we reopened the human trial thinking, well, let's go back to the drawing board. Maybe we can do this. There was a lot of pressure, because if it didn't work, we were going to just be another group trying to achieve something that was maybe not achievable. Our team went on a series of procurements without intent to transplant, looking at the allograft, making sure that the blood supply was appropriate. You can see what this looks like, the inferior thyroid artery here. The esophageal segment is behind it. Long segments we were able to procure and preserve very robust blood supply in the distal aspect of the graft. The patient that we had intended to consider for transplantation, and we had several on the list, was a middle-aged female. She's actually in healthcare herself. She was intubated traumatically for an asthma attack, and then subsequently had 6 major surgical operations at every place from Boston to Midwest to try to reconstruct her. And this is a very typical case where they kept placing extended tube tracheostomies, and those extended tubes would go further and further down until she was just a centimeter or so above the carina. When we had met her, she was bound to her apartment. The extended length tracheostomy tube was routinely obstructing and back walling into the granulation tissue, and she had a complete cricoid stenosis, so she had no laryngeal airway. We were waiting for COVID to pass, and January 13th, a year and a week ago, she had presented in extremis and said, either do the transplant or I want to be extubated, to die. We had been waiting for a male donor, and I'll explain why we wanted a male donor, but long story short, amidst the COVID kind of pandemic, we decided to do the transplant. We brought her in. she was assessed using the kind of typical complement-dependent cytotoxicity assay, as well as flow cytometry, which was negative, and she had no evidence of there were no evidence of donor-specific antibodies. So we really had a good match for this. The way we did this was not unlike what you all have already seen. We cross-clamped and perfused her with UW solution across the aortic arch to perfuse the entire thyroid and segment, and drained it out through the internal jugular veins. We cross-clamped the esophagus and the trachea just prior to procurement to prevent soiling the lower field, where they were procuring a liver at the same time. The graft itself was 11.5 centimeters that we procured. It included the cricoid. She needed a cricoid. And what we did was, in the esophageal segment, we split the esophagus in the back, preserving the blood supply, and I just peeled out the epithelial lining, the mucosa, so in an effort not to develop, mucocele in the operative field. So we could peel this out very quickly and preserve this arcade, and took the graft all the way down to the crine and then trimmed it in order to fit into position. The vascular supply, that we used the donor left lingual to the facial, and here the internal jugular, you can see end aside. What we did was we did this microvascular anastomosis and then released it to decrease the warm ischemic time. And with just one side, we had beautiful perfusion of the entire graft. That being said, this was a first in human. We weren't sure what we were going to get, so we went ahead to the opposite side as well, doing facial to common facial and the inferior thyroid to transverse cervical artery. So we had excellent blood flow through the graft just with one side, but we did both sides, and I think that was important. What we did was, the warm ischemic time, by the way, was 26 minutes, and the cold ischemic time was 78 minutes. We had lined up the OR side by side, and we left a port open. This is how we had the endotracheal tube running down through this cricothyrotomy, and at the end of the procedure, I left a small port so that we could do bedside bronchoscopies. The entire segment was 9 centimeters, and intraoperatively, we started antithymocyte globulin, and then we used kind of standard triple immunotherapy with tacrolimus, mycophenolate, and steroids, similar to what you would do for a kidney. On day 6, we used endoscopy to demonstrate the vascular arcade using narrowband imaging, and we could see beautiful blood flow through the mucosa. And at the bedside, we could perform endoscopy. Now, this is after suctioning. I will tell you that, interestingly, and we'll talk about this in a second, the loss of ciliated epithelium that comes with ischemia leads to a tremendous amount of accumulation of mucus that requires suctioning 7, 8, 9 times a day. The biopsies on day 6 demonstrated, kind of a squamous metaplasia. We lost the ciliated epithelium. So whether that's ischemic or what have you, you lose the ciliated epithelium. But by day 18, the epithelium regenerates very quickly. And in fact, by day 18, the constant suctioning that was required early on is no longer required because it starts to move the mucosa. And we placed in dye studies, so we would drop in distally at the carina, dye, and watch it traverse, so that functionally we knew that this was working. But also interestingly was the biopsies that we did. Even on day 18, we did cytogenetics on, and we found that the donor graft was composed of 0.4% of recipient epithelium. Just like we saw in the mouse, the recipient epithelium was growing into the graft. And in fact, when we got to day 42, we had completely normal architecture. And now we were up to 6.5% epithelium that had migrated into the graft. And by day 86, it had jumped up to 80%. So the epithelium had regenerated, but it was the recipient's epithelium that had migrated into the donor segment. And we had developed and created a chimera, an immunologic chimera. And the implications of that are very interesting because, as you all know, in vascular composite allograft transplantation, the rate of acute rejection is about 80%, and the rate of chronic rejection is about 50%. But yet in this allograft, we have seen no evidence of rejection. The lining has been beautiful throughout. We have not seen any vesicle formation. We have not seen any development of infiltratus on the biopsies. And interestingly, we've been monitoring the free cell DNA, and it has remained undetectable, suggesting no inflammatory response. So the development of this immunologic chimera may have a very important implication on staving off rejection. So it's a very interesting topic for study. Speaking back to the work we had done in the murine model, what we were seeing was this model actually turns out to be a pretty good predictor of what we're going to see in the human. And that's very important because as we further study all of the questions that are now arising, we want to know, can we rely on this model? I want to hit on one thing because it's always a question about the work that Pierre Dallaire in Belgium has done, which is really incredibly innovative work. And he has a litany of papers where he does a bunch of different things. One is that he'll take donor trachea, place it into the forearm, let it revascularize, and then he takes buccal mucosa from the cheek and places it inside the lumen and then transplants it in. And I think this is incredibly inventive work and very exciting. But I would say that the epithelial construct and the movement of mucosa and the mucociliary blanket that's so important for these long segment defects may speak to the fact that this may have limited application on the long segment defects for all of the reasons that we've kind of gone through. The use of buccal mucosa probably does prevent scarring, but I'm not sure that it creates a functional allograft. So through this process, we've actually learned a tremendous amount. Number one, we've learned that single-stage vascularized transplantation actually is possible. We have learned that standard immunosuppression is more than effective here. And we do have questions into whether we could de-escalate immunosuppression and why is that possible given we're kind of on the polar opposite of the rest of VCA transplantation where you see this high rate of rejection. We've learned that the allograft initially sloughs the epithelium, but it re-epithelializes in a chimeric fashion, at least in the first 100 days. And the implications of this are quite fascinating on many levels, and we can talk about that if we have time. But this really highlights the intersection of the epithelial science with the transplant immunology, and we're working on stem cell science to look at some other things. We are focused now on the possibility of de-escalation. Could we lower this down, monitor rejection, and see what happens? We are looking and have spending a lot of time looking at exosome release. When you harken back to that slide that I placed about direct and indirect allorecognition, the data that we've seen in our laboratory and actually some of the data that's coming out, or a lot of the data that's coming out in transplantation immunology doesn't necessarily support that the standard direct or indirect pathways of rejection are responsible for VCA rejection, and it may be exosome release, these vesicles that are released by the allograft. And so we're looking at exosome blockade, and it may be that the loss of epithelium decreases the exosome release, which is why we don't see rejection. So we're looking at epithelial signaling, and we're looking at the impact of this chimeric allograft, and is it causing a local environmental or even a systemic tolerance, because we're a little bit on our heels as to why are we not seeing any forms of rejection. The standard thought had been when you do a hand or a face, the skin is so loaded with dendritic cells, antigen-presenting cells, that leads to this hypersensitization and rejection. But interestingly, we're not seeing that in the trachea. So it's been exciting tour of duty. I'll be honest with you. I'm not sure that I ever thought we would do and perform a human tracheal transplantation, but it has given us new life in terms of thinking about the science of VCA transplant immunology. I'm presenting to you today, but all of you on the call realize that this is a village, a huge village that dates back for me 25, 28 years to people that were critically important, including Rob and Marshall and all those who have come after doing face transplants, but all those who've supported me throughout the process. So I appreciate the opportunity to chat with everybody, and happy to take some questions. How do I take this off share? Go.
Thank you so much, Dr. Genden. That was very, very fascinating, the journey to get to that first human transplantation. Just before questions, I just want to remind everyone that we do have CME available. We'll be sending out the code afterwards. And I just want to give a big thank you to Christine Fleckenstein for securing CME for today and the future grant rounds. So I'm going to open up for questions.
Jamie, maybe I could start with a couple comments. So first, our outstanding lecture. Thanks for giving us the time. I think for all the young people who are listening to you, Dr. Genden's whole research focus, career, and just dedication to this topic is something that needs to be admired. I can remember as a medical student listening to his interest in this field, and it took decades really to achieve what he achieved. So just, it doesn't come overnight. Just can't imagine the number of challenges and hiccups and, things that you had to overcome over decades. So I want to salute you for a career that's really been an achievement of success. Really amazing.
Thanks, Rob. Well, you have been a big inspiration. I mean, I think that we kind of feed off of each other, and it's it's not the most popular area of study, and there's a lot of people out there that question, is there a role for it, and so on and so forth. But as we enter into a world where transplant immunosuppression and immunobiology is changing, really changing quickly, it raises the question, why aren't otolaryngologists at the forefront of this, right? We've seen our plastic surgery brethren who are doing hand and face, but what about auricle transplants, nasal transplants? There's a lot of things that can be done, and as immunosuppression becomes much more donor specific and much less systemic, much less toxic, there's going to be an important role to consider transplantation of these organs. And so it would be great to have, our people at the table engaged in that kind of science.
Agreed, very much agreed. There is a tremendous experience with transplant down in Colombia. And we actually had Dr. Tintanago come up here and give us a couple lectures, and we were lucky enough to record them because, as you know, he publishes very little, speaks very little outside of Colombia, and it's challenging sometimes to understand his lessons learned. And so I posted a couple recordings of his 2 videos right there, and you started to get to that concept of chimerism, and he really speaks directly to the possibility of chimerism. And again, you'll leave it up to the people who might want to watch those videos because it's challenging to understand exactly his viewpoint. But you could make it of what take away what you can from his lectures.
Yeah, no, I have to take a look at those.
And the difference was, he didn't have the microvascular capability that you and I take for granted. I'm not a microvascular surgeon, but I know you are. But they couldn't do any kind of small vessel anastomosis. So what he did was he went from, the superior thyroid artery out to the external carotid, out to the common carotid, out to the subclavian, finally he just took a patch of aorta with the subclavians and the carotids coming off of it, and that's what he actually anastomosed in. And then same thing on the venous supply. So there was no microvascular whatsoever. And therefore, he's able to basically transplant the entire unlaga of the trachea, the esophagus, but very interestingly, also the thymus. And so when we asked about his ability to remove immunosuppression long-term for some of his patients and the ability to develop chimerism, he attributed it to the transplantation of T cells from the thymus. Now, again, I don't know if he has much data to support that, but the concept is buried in these lectures that I offered the folks here. Yeah. And then the thing that I took two things away from your lecture. One is how unbelievably challenging tracheoesophageal fistulas are. You know, we see these things, right? There's a little hole, 1 centimeter in the back of the mid-trachea, and, you know, we think we're going to put a little something in there, and then we figure we need to put a free flap in there, and then you take the esophagus away from the trachea, and the entire trachea dies, and it's necrotic. Believe us, we have been down this road way too many times. Yeah. And I like how you just kind of presented, you know, tracheoesophageal fistulas are lethal. And I don't think anybody's have really ever just stated it that clearly, but I think the challenge of those is underappreciated. And then the second thing I also appreciate from your lecture is the importance of the mucociliary transport. And so, you know, we do a lot of stenosis work here, but commonly patients have patent airways, but they still are pretty miserable because they haven't been able to achieve that very nice mucosal transport that you identified as being key. So those are the two big things I took away. Fantastic lecture. I'll leave other people to see if they have questions.
Yeah, and a couple of things. I mean, to speak to that, I think it's really important. This is the best thing about lecturing is you get to hear people like you and others, you know, the thoughts. I think number one, TE fistulas, they are lethal, and I actually think that the role of what we're doing here is not so much tracheal transplant. It's actually going to be TE transplant, and we know that when we procure this, you've got good blood flow in the esophagus as well as the trachea, so we can take that whole segment, and I think we're looking for the right patient. I think a TE reconstruction would really benefit the sickest of patients. Number two, the idea of chimerism and the impact of it turns out to be much more interesting than we ever thought, because the organs that we're transplanting are very different than the parenchymal organs, the solid organs. And so the ability to study the role of cells moving in and transferring, I think, is going to keep us busy for a long time. But yeah, I appreciate your comments.
Jamie, this is Usman, and Dr. Genger, this is Usman. I'm one of the thoracic and lung transplant surgeons. Before I ask my questions and I lay out my long congratulatory statement, I want to make sure there's no ENT trainees who want to ask any questions. I don't want to interrupt any of those guys. Jamie, do I
have a comment and also just a question as well. Can you guys hear me okay?
Sure.
Hey, Eric, this is Patrick Byrne. Fantastic lecture. And I got to echo what Rob said, the systematic and patient way that you and your team explored a solution to a really terrible problem is such a lesson to all of us. It's really just so captivating to listen to you today. And so congratulations on such an incredible body of work.
Thank you.
You brought up something that really struck me. So I joined Cleveland Clinic not long ago. At Hopkins, I was one of the co-directors of the face transplant team for about 7 or 8 years. And one of the elements that really captivated, I think, a lot of us was this notion that the future from moving from immune suppression to immune modulation, from seeing these VCA transplant patients shifting from traditional triple drug to a single drug therapy, opened this promise that, well, maybe the risk-reward discussion is far different in the future than it is now. And you brought it up. I was glad you did. I'd be curious, any other insights you would share with us, how you're expecting or managing the immune suppression on your patient, and whether or not you foresee for tracheal transplantation a similar opportunity to move to far less risky, potentially risky protocols for immune modulation.
So I think that that's going to be key, right? Because you've got to be able to justify doing these transplants, whether it's face, hand, any of the VCA, and balance it out with the toxicity. So we are flirting with the idea. You know how this is. The first one that you do, you just want it to survive. You don't even know if the graft is going to be vascularized. And so we were full bore, you know, mycophenolate and the whole thing. And now we're thinking, toying with the idea of, do we de-escalate? Do we back off? You know, we can drop in a bronchoscope and look at the trachea and monitor it. It's not as easy as looking at a hand or a face where you typically see that vesicle formation in the skin, but we are toying with the idea, but we haven't yet committed to it. And I think that this is where we have to go. I mean, what's interesting, and I think the most interesting aspect of this, is that we have not seen what we typically see in VCA transplants. We have not seen this acute or even chronic rejection. Now, it's only a year, and that may change, but we're not seeing even the cellular changes in her blood, mucosal changes to suggest it. There's something more going on here, and I may not be smart enough to figure it out in my career, but clearly somewhere along the idea of chimerism or donor transplanted cells. The other thing I didn't bring up, which I think is actually really critical, and this is a little peek behind the curtain, we waited for a male donor, and in particular, I wanted a male donor who was an organ recipient. The donor was immunosuppressed. So he was a kidney recipient. And we had theorized for a long time that the immunosuppressed donor may be the best donor. And that's where we're looking at as well. So you can imagine a situation where you have somebody ready for procurement and you immunosuppress them for 48 hours before transplantation. What is the impact of that on skin-bearing transplantations or mucosal-bearing transplantations? So the short answer to your question is we are flirting with the idea of de-escalation. We're not there yet. We're a little bit more fascinated by why she's doing so well, to be honest with you.
And then a quick follow-up question: any comments on your protocol for monitoring? It's such a different than a face or hand, where we can so quickly and easily see skin changes, for example. Any just insight share with us?
Yeah, so two things. One, we left a small port up at the tracheal thyroid area so that we could drop in a scope, which we did 6, 7, 8 times a day early on before she regenerated epithelial migration and movement of the mucosa, and we would suction her out. And sure enough, she had loads of crusting. And then we hit like day 18, 19, 20, and all of a sudden she started to clear this stuff. But we could monitor it, and we're closing her up this week. I've left open a very small port to continue to monitor this with for all the reasons you just raised. But we were basing this off of the work that you all have done. Did we see sloughing later on, vesicle formation, erythema? We did biopsies. Did we see any infiltrate? We haven't seen any of that. Not even a little bit. And that to me is probably the most curious thing. You know, why is that? The mucosa and the lining of the trachea is loaded with DCs and APCs. So is it the donor that was immunosuppressed that decreased the sensitization and the prompting of the immune system? Is it something different about the chimeric state? I don't know, but we hope that the lessons in here are going to really help hand, face, and other VCA transplants.
Thank you,
Dr. Genden. That's fantastic. We've followed your work very closely. Since we deal with the bronchial anastomosis a little bit lower down in the chest for the lung transplant portion. This stuff that you presented today and you've published is revolutionary, and we look forward to more. We've done some stuff on our own, and I'd love to get your thoughts on two things. First, we're learning in the world of lung transplant that the role of the microbiota and the strata of the microbiome really affects not just the healing of the anastomosis, but also plays into the immunologic complement of the graft. Can you comment? I'm sure you've looked at it. Can you comment on what happens in the tracheal allograft versus the native airways? in terms of the microbiologic components?
So the microbiome of this is an area that I don't think is studied enough. I think you're right on the money. You know, there is this beautiful forest and balance of bacteria and fungus and so on and so forth that is critically important to the status of our health and just general homeostasis. And I think when that's disrupted, so we actually culture the donor and the recipient prior to, because we do strongly believe that a disruption in the bacteriology and the microbiome is a major problem. It's a major problem for a lot of ways that we're probably not even sure of, but one of our theories here is the fact that this graft is not demonstrating rejection. We don't believe that direct and indirect pathway, the standard pathways of rejection, are at play here, but there's probably what we believe is a semi-indirect way, which is through exosome release, the release of these allogeneic vesicles that trigger allorecognition, and some of those vesicles may be released at a higher rate in an environment where there's either a balance in the microbiome, an imbalance in the microbiome. I think it's an area that's ripe for research. I think you're right on the money. I think whenever there's an imbalance in microbiome, that's why we see stenosis, restenosis, chronic problems with these things, and I don't think we pay attention to it. If you look at the rest of the world outside of our thoracic and ENT world, this is a big issue in gut. It's a big issue in transplant. Patients who have disrupted microbiomes reject organs at a rate of 30% higher than those who don't. So, there's a massive database that's available to demonstrate the normal microbiome of over 100,000 patients. And you can compare that. And now it's not, we don't culture, as you know, we do, S16, SR16, we do immunotyping and genetic typing. You can determine how far off the normal is your patient. And I think you're absolutely right. I think there's a lot to be said for this, and I think it's an area that's ripe for study.
Thank you. My second question is a bit more technical, and I'll touch base with you later as well about that. But for the ciliary reepithelialization to happen in the allograft and for that chimera to form, does that graft have to be interposed in the patient's airways?
Yes. So if you're saying, does it have to be orthotopically placed into the? Yes. So if you do this heterotopically in the mouse model, for example, you need to have, there's movement of the cells, and we can watch the basal cells in the reporter mice move in, and the cytogenetics that we were using in the human demonstrate this marching of basal cells into the graft, and then differentiation into ciliated cells. So you do have to have these in continuity. The other issue that comes up, and one of the things we're looking at, is does the same thing happen in the vascular network? Do you see endothelial movement into the vascular network of the donor tissue from the recipient? And does that play a role down the line? Because when we talk about de-escalating immunosuppression, one of the major issues in what happens in VCA transplant is microvascular obstruction. They develop clots and thrombosis as a result of disruption of the endothelium. So if there is that chimerization and growth into the vascular network, how far down does it go, and is it protective? Are really key questions.
Yeah, the reason I bring it up is you could certainly theorize that you could harvest a composite graft, the tracheoesophageal graft, and hook it up to the radial artery and vein for a week or so, let it settle down, and then transplant it to the recipient in the orthotopic position. If your epithelium is sloughing off at about day 7 to 8, and by that time you've established vascularity and let the graft settle down in the recipient's body, that could be something to think about to transplant it at that time in a more controlled fashion.
Yeah, it's an interesting idea. One of the things that our lab is working on is actually stem cell implants. So what we do is from the, when you take from the recipient stem cells, you differentiate them and plant them into the donor graft, allowing them to seed the graft, to decrease the immunogenic, nature of the graft. And you could imagine placing that in a radial forearm or a gut or wherever you're going to revascularize. Is it absolutely necessary? I don't know. I don't know. You know, I think we're starting to get to a point where you may be able to just place this orthotopically right into the organ and let the organ. We didn't have a tremendous inflammatory response when we did the transplant. We were expecting one, but we didn't see it. Why is that? So these are all great questions. I agree with you.
Well, thank you very much. Great to have you with us today.
Any other questions in the audience? I have a question, Dr. Genden. So looking forward, obviously there's many questions to be explored and answered, but when do you anticipate would be like the timing for the next human transplantation?
Yeah, I wanted to get out a year. I wanted to make sure that this was safe. I'm also not the type that's going to beat the drum and run across the country and say, oh, you've all got to be doing this. I think that this is going to find its way if it's meant, if there's a place for it in kind of what we do in medicine and surgery, it will find its way. I don't need to be the one to push it down the throats of the rest of the medical community. I'm waiting for the right patient. We've had, as you can imagine, a lot of patients that have come forward, but they're not ideal patients. And we want to choose the sickest who really need it, but the ones who are going to tolerate it. So the elderly don't do real well with immunosuppression. We want to find somebody, that's the right for it until we really get this off the ground. We feel comfortable with it. I would really enjoy the opportunity to take on a tracheoesophageal fistula patient, because I really feel that we could help that patient, and that may, like I said, be kind of the area that we can lend the best care to. So we're keeping our eyes open, and we'll have to see what comes down the pike.
And do you think it's important for the next one that the donor also be immunosuppressed?
I have no data on that. This is something we've theorized for a long time. We've played with in our animal models, and I don't know if I'm going to be able to get the team to allow me to immunosuppress the donor next time. But boy, I'm going to certainly try. The other issue is maybe we don't, and we now have a control group.
Yeah, to compare.
Yeah.
Amazing. Thank you so much. Any other last minute questions? It's 8:09.
One quick last one, Jamie. Dr. Genden, unbelievable talk. Joe Scharf, one of the head and neck surgeons. Issue of parathyroid function at all? Do you worry about that, transplanting him, or how do you handle that?
So the thyroid and the parathyroid come in. I didn't get a chance to get into it, but the patient developed hypercalcemia. She developed primary hyperparathyroidism. So you would expect that there would be that feedback loop, but in fact, it didn't happen. So she has mild hypercalcemia and elevated PTH levels. And if we were ever going to de-escalate or pull immunosuppression off, I'd probably go back and do a thyroidectomy and parathyroidectomy on her. Every now and then we send the patient for a thyroid ultrasound over to one of the endocrinologists just to watch their faces when they see that she's got 2 thyroid glands.
All right. Thanks so much. What a great lecture.
By the way, thank you guys for training Scott. You did a great job. We're already tired of him saying, at Cleveland Clinic, this is how they did it. But it's been a great opportunity, and we really appreciate it.
Well, if you're sick of them, send them back to us. We'll take them.
Okay.
Yeah, Eric, this is Fritz. That was an amazing lecture. Congratulations.
Thank you very much. Appreciate it.
All right. Well, I think Paul.
Yeah, I just wanted to thank you as well. It's like very inspirational to watch the process, and I'm one of the laryngologists here at the clinic, and I just commend you. It's something to share with our residents and share with, honestly, anybody who wants to tackle a big problem. So it's just very inspirational, and I thank you.
No, listen, you guys have all been an incredible part of my education, and we all do this together. I mean, this is what it's about. We need to push each other forward as a specialty. There's a lot to be done here. So I appreciate the opportunity to speak to everybody, and hopefully we'll have a chance to collaborate. I'll keep sending people out there for you to train so that I can drain your brain and bring them back here. But thank you very much.